Good morning. Oh, pretty good for a Monday morning. Just wait for a few more people to take their seats. On behalf of the Office of Behavioral and Social Sciences Research and the Conference Planning Committee, it's my pleasure to welcome you to the 4th Annual NIH Conference on the Science of Dissemination and Implementation. I think you can see by the size of the room that we've had yet another record turnout for this year's meeting, and I think reflects a growing recognition of the need to address how best to ensure that scientific advances ultimately make a difference in improving health. This year's conference theme, Policy and Practice, is intended to stimulate dialogue on the connections between public policy, practice, and health research. The health policy landscape has changed a lot in recent years, not just here in the U.S., but globally, and we believe a focus on this is both timely and critical to closing the gap between research evidence and policy. More and more, we recognize that health is a global issue and that many policies that influence health are, in fact, made outside the healthcare arena. Population health is intimately linked to a government's broader social, economic, and environmental policies. Appreciating this, we welcome the contributions of our international colleagues attending this year's conference. NIH is also particularly pleased to be joined this year by the Veterans Health Administration and the Agency for Healthcare Research and Quality, and I know will benefit from their increased presence at this year's conference. I'd also like to acknowledge the people on our planning committee and our external scientific advisors who donated their time to develop what I think is really an outstanding agenda. We'd also like to thank the Donahue Foundation for the poster session reception this afternoon, and I hope that all of you will attend that gathering. And last but no means least, I'd like to thank the Hill Group for their superior logistical support. I have just a few announcements before we get started. First, I'd just like to point your attention to your badge, which lists the sessions for which you pre-registered. Note that this year we're really going to enforce the capacity for the think tanks. I know they're pretty popular, but if you didn't pre-register for one and you want to attend one, please check with the registration desk to see if there's room. Otherwise, just go to a session where there's spaces. Also, because of the weather, the hotel is going to accommodate us and offer a buffet lunch, or also I think boxed lunches will be available. So if you don't want to go out, you'll be able to get some food for lunch at the hotel. If you do want to go out, there are places in walking distance, and you can get a list of restaurants at the registration desk. You'll also note that there are several display tables with information about implementation research training opportunities. And thanks to the VA, we've compiled a directory of implementation science training programs, which you can see at the conference website, or there are also handouts at the registration desk. And I'd also like to draw your attention to a new training opportunity being offered by NIH this August in North Carolina. It's a training institute on dissemination and implementation research in health. And more information about that can also be found at the registration desk or at this website, or if you check the OBSSR website, it'll give you more information about the goals of the Institute and how to apply. The applications are due April 15th. Now, I'd like to turn it over to Dr. Robert Kaplan, who's OBSSR's new director. He joins us from UCLA, where he was professor in the Department of Health Services at the School of Public Health and the Department of Medicine. He's had a long and distinguished career as a behavioral scientist, and I think many of you know him from his leadership at the American Psychological Association and also the Society of Behavioral Medicine. NIH is extremely fortunate to have recruited such a leader. So please join me in welcoming Dr. Bob Kaplan.
Well, thank you very much. What a pleasure to be here and to see so many of my old friends all in the same place. It's like going to the best scientific meetings. So it's a pleasure to be here. I think many of you know that I'm a very seasoned NIH employee. I've been here almost a month, or a little bit over a month. So it's great. I'm learning all the acronyms, and it's going to, I'd say, if you check back with me in a year or so, I'll be about halfway down the list. But I would like to take the opportunity to thank Helen Meissner. Helen organized the conference in collaboration with the organizing committee, and what a lot of you don't realize is that she's very well recognized at the NIH. Last Friday, when I was cleaning up my office to go home, I got this little envelope that was a citation from Director Collins, and it says, "In recognition of outstanding leadership in NIH programs in the science of dissemination and implementation and in health disparities." And you can see Helen there holding her award with Dr. Collins on, be her right side, and Dr. Tabak and Deb Olster, the Deputy Director of the Office of Behavioral and Social Sciences Research. So we appreciate her, and it turns out that everybody appreciates her. So thank you, Helen. I just want to make a few introductory comments. I think to this group, this is very old stuff, but when I go out and talk to people, the world out there doesn't really recognize how important dissemination and implementation sciences are. We spend billions of dollars developing new cures, and we work very hard to build better pills. And in fact, discovery drives this enormous pharmaceutical industry and device industry in this country. Yet something's missing. Steve Wolf, whose papers I read in preparation for this, points out that for every $1 that we spend developing new pharmaceutical products and new interventions in medicine, we spend about a penny on developing or studying new ways to implement these new products. There are enormous numbers of new randomized clinical trials, so we have lots of new information. This just summarizes the new risk factor treatment trials that were published between 2004 and 2009. 2004 is very important because that's the last year that we revised the major guidelines for prevention of cardiovascular disease, the ATP3 guidelines and the JNC7 guidelines. And since then, there have been 41 new randomized clinical trials. Also, it's worth saying that epidemiologists continue to produce new information, but in fact, in areas like cardiovascular disease, we pretty much knew what the risk factors were for coronary disease when the first publication of the Framingham study was published in 1961. That's about 50 years ago. Now, I think this is going to be a little bit hard to read, but we know from a lot of different evidence that we aren't reaching significant portions of the population that we want to reach. Now, we're getting better, and it's worthwhile to say that we're doing better each year. Each time there's a new edition of the National Health and Nutrition Examination Survey, the numbers look a little bit better. But still, among people who have hypertension, as identified in the NHANES study, only about 80% of them actually know that they have hypertension. And among those, only about 70% are treated. And among those, only about 50% have their hypertension controlled. Now, this is actually much better than it was 20 years ago, but there's still significant numbers of people who could do better. And the left side of the slide shows that this varies actually rather dramatically by socioeconomic status and race. So if you work through these numbers, if you say that among all people who have hypertension, just as the example that we're considering, only 80% of them even know they have the condition. Among those, about 70% are treated, and among those, about 50% are controlled. That means that only about 28% of people who could benefit from treatment are actually getting the full benefit. And actually, we know from very systematic studies that most people can have their blood pressure controlled in very carefully controlled situations. It might take them 2 or 3 drugs to get there, but it can be achieved in most cases. So we have a lot of ground that we could cover through better dissemination and implementation. And it's also worth saying that we're doing relatively well in relation to other countries in the world. So, for example, there was an IOM report that was published relatively recently that suggests that diseases like coronary heart disease now account for about 30% of deaths in middle and low-income countries. And these tend to be overlooked by governments, by global health institutions, and by developmental agencies. But if you look at some countries, and one of the most shocking examples was that in China, only about 6% of people who are aware they have hypertension in China have their blood pressure controlled. So, we also know that some relatively simple interventions might have substantial potential to fill this gap. So Steve Wolf and Johnson reported just a few years ago through sort of back-of-the-envelope simulation that simple reminders, so office reminders, for example, they estimated that they would prevent 7 times more death than replacing older cholesterol-lowering medications with newer ones that are considered to be more potent. So the investment in dissemination actually might produce significantly more health benefit than finding that better pill. I'll just give you a quick example. I recently looked at a whole bunch of the randomized clinical trials. So again, we identified 41 of them that were published between 2004 and 2009. Now, it turns out that when you look across the hypertension studies, they vary a lot. If you look at the All-Hat study, it turns out that a lot of the newer studies produce results that are somewhat inconsistent. But it's worth saying that a 10% change in mortality rate associated with new medication would be extremely rare across these studies. So we just say, well, let's assume that it would be a big benefit, and there would be a 10% reduction in hypertension-related deaths in comparison to current therapies. And if you assume that you had a population of 100,000 that you would be working with, that might save 10,000 lives by getting to this better pill. But if only 50% of the people use the medication in a manner that provided full benefit, the lives lost due to poor dissemination are about 5 times greater than what you would get by going to that next best pill. So I think this is an extremely important science. By the way, when we get beyond the medical side of it to community dissemination, the problems become even more challenging and perhaps even more important. So I'm very enthused to be here, and here are some of the take-home messages. First of all, we have a very large investment in building better treatments, which I'm in favor of, by the way. I don't want to leave you with the impression that I don't think we need to continue this big investment in better treatments. But there's substantial evidence that dissemination and implementation is not optimal. And there's potentially a huge payoff by improving the science of dissemination and implementation. So I'm really thrilled to be here, and I'm thrilled to be part of this, and I'm thrilled to be working with people like Helen and Russ Glasgow and the others who have been teaching me about this. But with that, I have the privilege and opportunity to introduce today's keynote speaker, who's Dr. Carolyn Clancy. And I think many of you know Dr. Clancy, so I won't make the introduction long, but just to say that I think that she's one of the most important leaders that we have in our science, but also in the government in general. Dr. Clancy is general internist. She is the director of the Agency for Healthcare Research and Quality, a job that she's had since 2003. Before that, she was the director of AHRQ's Center on Outcomes and Effectiveness Research. Dr. Clancy was trained at Boston College and the University of Massachusetts Medical School. She was a Henry J. Kaiser Family Foundation Fellow at the University of Pennsylvania. And she had a career in academia at the Medical College of Virginia before joining the government. Dr. Clancy is a member of the Institute of Medicine. She also is a master of the American College of Physicians. And in 2009, she was awarded the William B. Graham Prize for Health Services Research. She has a broad range of interests, and she's, I think, done more than anybody that I can imagine in trying to bring together the mission of the AHRQ with the NIH and a whole bunch of other agencies within the Department of Health and Human Services and all across government. So, Carolyn, it's a great pleasure to have you here. I think that Carolyn actually was once my project officer, and we worked together on the National Emphysema Treatment Trial. So, it's great to see you and have you here.
Thanks so much. Very much appreciated. Well, good morning, everyone. I really want to congratulate the conference organizers for starting with hail. Now, I mean, is that a way to wake you up to how important this is? If there's one message I leave you with today, it's that not only is this work important, all research is and science is by definition important, but it's really showtime for this country, for this kind of work, and we need it to sustain the opportunity provided by the Affordable Care Act, where we can get to a place where at ARC we're no longer funding so many studies documenting yet again that people without insurance get crummy care, just as one example. But we've got a huge amount of work to do, so I'm going to jump right in and actually build on Bob's comments. You'll think we rehearsed, but actually that's not the case. Great. So I'm starting off with a picture of Peter Pronovost from Johns Hopkins. Now, we had the privilege of supporting his work, the Keystone Project. Now, I have to tell you, this project has changed my social life, because when I go out with my husband, and some of his colleagues and friends ask, what do you do? He always gives me this murderous look that pretty much says, keep it short, no details, do not geek them out. Now I can simply say, do you read The New Yorker? And we have a very pleasant conversation. But the reason I emphasize this study that achieved dramatic and sustained reductions in serious central line infections, which, by the way, have a very high case fatality rate, is it's one of the few home runs I can point to in healthcare. The intervention they developed and tested worked at very large medical centers like the University of Michigan and in small Michigan hospitals as well. And we're now working with him and the American Hospital Association to expand this literally across the country. Now, I don't want to pretend that every hospital has jumped on board and said, we're there, we're with you. It's more like about 25% have enthusiastically stepped forward. But you know what? Those that have, they're seeing exactly the same sorts of dramatic improvements. And his point in this slide and this quote is just that we have failed to appreciate just how big a challenge this is. And indeed, everything about the Affordable Care Act, in not exactly the most elegant language, but if you look at all the provisions in there around improving safety and quality, they all point to us building a healthcare system that is focused on the needs of patients and families. Now, for those of you who provide clinical care and think, but that's what I do, I totally agree with you. The system isn't so helpful, though. This past fall, my father passed away, and my entire large extended family got to be with him at the end, and that was all lovely. But I watched my siblings, none of whom are in health or medicine. I'm the oldest of 7, so if you're one of 7, you can't be shy. It's just not consistent with survival and thrival. So I watched them ask questions, and they asked really what are good logical questions from their standpoint, but they were always kind of off point. And it made me realize just how difficult this system is to navigate for people who are well educated, much less people who come to this with more challenges. So we've got a lot of work to do. So what I want to talk to you about is what we're up to at ARC. I know some of our NIH colleagues are working so hard they don't always know all about ARC, so I just thought I'd give you the very, very brief overview. And I want to share some high-level findings from our annual reports to the Congress on how we're doing in quality and disparities. And then I want to get into the issues of dissemination and implementation and draw the line from the science that you're doing every day to health system transformation and patient-centered care. So just at a very high level, big priorities for ARC are improving the safety and quality of care. Notice I'm not saying conduct and support research that will one day hopefully get us to, that someone will use, and then they will improve care, although that's really what it's about. But we take the urgency facing healthcare very, very seriously. And we also take seriously the dedication of healthcare professionals across this country in all disciplines. Every one of them gets up every single day to do the best job they can, and they work in systems that make that painful and difficult, and it's almost never really the default easy thing to do. So we've got a lot of good work ahead of us. We also support work in the effectiveness and comparative effectiveness, what we're now calling patient-centered outcomes research. We've had very explicit authority since the Medicare drug bill passed in 2003. Now, very interestingly for all your work, that authority has three parts. The middle part we know all about, support and conduct and so forth. The first part says researchers don't set the priorities by themselves. The priorities are actually set in close, transparent collaboration with multiple stakeholders, public and private sectors. And the third portion says, and this is where many of you work, the information has to be accessible and available to multiple audiences and understood. Now, if you think about the fact that Bob talked about all the discoveries we've made, in 2011, it's a great time to be alive. We have no excuse for not doing a better job with hypertension because unlike the early days when the trade-off was between, living longer or not being clear if the drugs we were giving you were making it feel like it wasn't worth it, right? Now for many decisions, diagnostic, therapeutic, and so forth, we've got two or more good options. What we don't have is an easy way for people, clinicians and patients, to work together to figure out what's the right option for them. Now, every researcher who breathes gets up every day to make a difference in people's lives. Without question, it's a given. This is what drives them to work around the clock, late into the night, again and again and again, to resubmit that grant after all that constructive input from peer review and so forth. And yet that passion and the skill set of communicating effectively about benefits and harms of alternative interventions, particularly to people of health literacy, don't often co-reside in the same individuals. So that means the research team has to be bigger. And we do a lot of work trying to make data available for researchers and for hypothesis generation. Now, the Recovery Act was a huge boon both to ARC and to NIH and others, with a total of $1.1 billion coming out of that. I'll bet some of you are still tired from writing some of those grant applications, so let me say thank you. What's very clear is that the point of this was was a down payment on what I'll call the scientific infrastructure to make health reform sustainable. We know now that simply knowledge and awareness is not going to be enough to get us to systematically high-quality care. I know that when we see results that are less than what we'd all like for ourselves, that if you tested the doctors, nurses, pharmacists, and so forth, they'd all do exceedingly well. It's all about implementation and execution. That is the big part. So trying to figure out how we could make investments in robust systems and infrastructure to make the right thing, the easy thing to do, that is a key part of this work as well as a strong focus on the needs of what we refer to at ARC, taking language from our authorizing statute as priority populations, populations that are often not well represented traditionally in research. So, with apologies to Archie Cochran, I thought I would reframe some of the questions we ask about clinical interventions. For the work that we're engaged in together, for any intervention to improve care, the first question, of course, is can it work? But a very important sub-question is, do we understand how and why it worked? A second is, will it work here? In this particular context and in this particular environment, community, market, and so forth. And of course, the real showtime aspect here is, can we replicate it and scale it? I will mention a little bit later that, CMS now has up to $10 billion over the next decade to develop, test, and implement new models of care delivery, helping us to get to a place where our payment system is more aligned with the goals and outcomes we want from healthcare. That's fantastic. They're going to struggle with these issues as well. Lots and lots of good ideas in this country. We tend to be a little bit shorter on the execution side. So we've had the privilege in comparative effectiveness research over the past 6 years or so to work very closely with colleagues in the private sector and also to try to increase the knowledge base so that we get closer to this value proposition in healthcare. Now, before the Recovery Act, we got a total of $129 million over 5 years. So those of you who know anything about rough price tags for clinical trials will know that's not the business we're in. Our business, and this is what has made our collaboration with NIH in this area just so fruitful and wonderful, certainly for us, is to actually build the infrastructure and test and develop methods to learn from all of the data generated as a byproduct of providing care, and to figure out how can we aggregate that, and also know that we can be confident in the results. Sometimes we can't. Sometimes we're going to make mistakes doing that. But there are so many questions in clinical care and healthcare policy that are simply not ever going to be tested in a clinical trial. It just won't happen. People will consider it unethical or against their beliefs and so forth. So just turning to the annual reports we make to the Congress, 3 weeks ago today we released our 8th annual report. So the really good news is that every single year since we started doing this across all settings and populations, we've seen statistically significant improvements in care. Slightly less good news is if you look at that number, this is actually a little higher, the 2.3% number, than some other years. And if you think about the numbers you see associated with annual increases in what we're spending on healthcare, even when the economy has slowed down for the past couple of years, you can see there's an important disconnect that policymakers understand in a very clear way. And urgent attention is clearly needed to improve quality and reduce disparities in a number of key areas that I've highlighted here. Cancer screening, diabetes management. Just to pause on diabetes management for a moment, health plans have been reporting on quality for about 20 years now. And now they report not only whether the right tests were ordered, but also what are the short-term outcomes, including management of diabetes, management of cardiac risk factors, and so forth. Now, I want to set aside for a moment, I'm highly aware of the controversy about what's the right level of hemoglobin A1C, but we're looking at a level of about 9 here, okay? This is not as precise as we're worried about in clinical trials. The top 10% of plans get it right 71% of the time. Now, that's up from where they were a few years ago, so it's been steady improvement, but we're tolerating a failure rate in care for an important chronic illness of almost 30%, and that's in the best. So we've got a huge amount of work to do. Just to highlight a couple of areas, 2 areas that we saw improving were palliative care and end-of-life care, and patient and family engagement in their care. 3 that are lagging were population health, safety, and access to care. And 3 require more data for us to be able to say anything about care coordination. We supported a systematic review on this topic a few years ago, and the opening sentence of the final report says, "We don't have a single definition of care coordination." Well, we don't have very much good information on what are opportunities of wasting resources in healthcare, something of a sensitive topic. And all 8 areas showed disparities related to race, ethnicity, and socioeconomic status. So a lot of work to do. Now, some things are getting better, and that's really, really good news. Anyone here from NHLBI should feel very, very proud of the work that the cardiac and heart disease community has done in terms of door-to-balloon time. This is not easy stuff, requires teamwork and execution in a highly orchestrated kind of way, almost like music or dancing, I guess, and the proportion of people across this country who get their intervention in less than 90 minutes, that's the goal, has doubled in the past few years from something about 40% to over 80%. That is fantastic. We don't see improvements at that scale. And indeed, we see other areas of treating acute illnesses and injuries that are improving much, much more than that 2.3%. When you look at chronic illness management, preventive services and immunizations, improvements where they are much, much more modest. So in terms of, we take enormous pride and work for organizations and institutions that celebrate the notion of evidence-based health care and evidence-based treatment decisions. And indeed, the Affordable Care Act, in some ways, is a terrific model of evidence-based policy. You all may not have known that, but preventive services, for example, are exempt from copayments for those services rated A or B by the Preventive Services Task Force. That's just one example. But ultimately, the kinds of complex decisions that people have to make involve trade-offs for individuals, very similar to Barbara McNeil's famous study of people with head and neck cancer, right? She used healthy volunteers to ask this question, but the essential question she posed to them was, if you have surgery, you'll live longer. But if you have radiation, you'll get to keep your voice, which you don't have with surgery. What would you like? Now, at that time, by and large, patients weren't terribly involved in this conversation. They were pretty much told, this is what we're going to do. You're going to have surgery because it will increase your life expectancy. And 20% of people enrolled in this study said, no, I actually would prefer to have a higher quality of life, which touches on work that Bob Kaplan has done throughout his career. So we know that in order to give people some of the tools from the science that we're supporting, we've got to try a variety of techniques, including audio announcements in supermarkets. Indeed, I went to Safeway about 10 days ago. Not only is ARC there, but now we've been followed by CDC and FDA. I don't know who else is coming. We might have used up this space. But we also have a specific center that we support named for John Eisenberg, our former director, focused on communication and clinical decision sciences that develops prototype guides for clinicians, for policymakers, and for consumers. Same scientific base, but developed in a very, very different way. Now, we were really, really excited in this, an amazing amount of good work going on. In addition to the $300 million directly allocated to us by the Congress, 173 of the $400 million allocated to the Secretary's office is also being mobilized by ARC. And I have to say that it was really a fantastic opportunity for us to partner with NIH, not just on a project or an initiative, but for an entire portfolio. So just to give you a sense of some of the investments that we're trying in dissemination, we are supporting a publicity center and regional offices, looking for every opportunity to get this information to people. Bob started off with a slide that said only 80% of people with high blood pressure know they have it. Well, Lord knows if they show up anywhere in healthcare, we're going to tell them. But what about people who don't have a need to show up, right? How do we reach them? That's what this is about. We're investing in online continuing education. I don't see this as the Everest of our ambitions, by the way, but knowledge is necessary, if not entirely sufficient, for leading to the improvements that we have. We're testing different models of academic detailing and also evaluating those efforts to try to learn which strategies worked for what circumstances and so forth. Interestingly, when we started this work in comparative effectiveness, the focus was mostly on clinical interventions. Which of these many options is the right one for an individual? As a result of the Recovery Act and the congressionally required Institute of Medicine study, some of you may remember those top 100 questions, as well as the Federal Coordinating Council for Comparative Effectiveness Research and lots of stakeholder input, independently both groups concluded that the work needed to focus not just on clinical things, but on how we deliver them, or care improvement strategies. Now, on one level, that's great. On another level, I hope you all are ready for this challenge, and all your colleagues back at home. We all know what 20 milligrams of Lipitor is. We often don't know if we're reaching the right people with it or if people are taking it, but it has a standard meaning. If you fill in the blank for many of the strategies we're talking about, whether that's knowledge transfer, research utilization, care management, care coordination, disease management, and the list goes on, you've seen one. We simply don't have a standard taxonomy and definition of terms. Instead, we usually yell at the Congressional Budget Office for not scoring these as being worthwhile investments. And yet, most of the time, they're right, because we haven't built that science base. So if you were having any nagging doubts about how important your work is, I hope that you will put those to rest. Now, just to give you an example of customizing an explicit intervention, 2 years ago, a study funded by ARC at Boston Medical Center, Project RED, the re-engineered discharge, all right, actually used a nurse and a pharmacist to reduce readmissions by 30% in the next 30 days and also reduce return visits to the emergency room by that same amount. Now, in this world, that is fantastic, and right now at a policy level, all hospitals are going to have to address this challenge. How do we prevent avoidable readmissions? And having been my dad's navigator from here to Boston for the past couple of years, I'm just here to tell you there's a lot of low-hanging fruit. People go home without a clear sense of what they're up to and so forth. But the really interesting part is that 2 weeks before this study was published in the Annals of Internal Medicine, Boston Medical Center laid off a couple of hundred staff. Now, this actually raised some very important questions, right? Because the nurse and pharmacist involved in this study actually were brought in and superimposed on the people who worked there. I don't mean they were sitting on them literally, but I mean they were additional staff, right? And the question was, how do you weave that into core business, and who's going to have the resources when the economy is actually forcing us to lay people off? So the result was actually a virtual discharge nurse. And in this particular slide, I'm highlighting that they're specifically focusing on a virtual nurse with a strong focus on African American women. Now, we got to show this to Secretary Sebelius last year. I have to confess, when I first heard about this, I was a little nervous. I pictured my father plopped in front of a video nodding off. Well, if you've read The Tipping Point, it does all the things you're supposed to do for this kind of technology. You have to keep touching the screen. It's programmed for your specifics. And in fact, if you don't touch it within a certain amount of time, the bell goes off and a real nurse comes in. I don't know that this is the end of the story, but I mean, it is one very innovative approach. Jack Needleman, who I know is here, recently sent me the study he and his team just published in the New England Journal, showing that below target nurse staffing and high patient turnover are independently associated with the risk of deaths among patients. Wow, high stakes work here. And we have made a variety of materials available for clinicians. I'm just listing some of the ones that are most recently available, comparing oral medications for people with type 2 diabetes, antidepressants for adults, and the list goes on, all available for free on our website. And we're very, very excited about the expanded continuing medical education. Part of the reason I'm excited is that thoughtful leaders in this area know the continuing medical education, if it's going to continue to have an important role, has got to be linked more directly with the delivery of care. And they also know that the days of, I'm thinking of an old flyer I got, taking a little trip to SeaWorld for the weekend to learn about flexible sigmoidoscopy are pretty much over, right? I mean, we're all about making this online and visual. So we're putting resources out there for educators to use. And my favorite part of what we're doing in patient-centered outcomes research is actually the patient guides, because it demystifies what it is that we're talking about. A number of them provide questions for patients to bring in with them so that ultimately they can be more active partners in their own care. Now, the Affordable Care Act also made resources available for something called the Patient-Centered Outcomes Research Institute, or PCORI. I know Brian Mittman is here somewhere and was on the planning committee. Brian is actually a member of what we've been referring to as the Rockstar Methodology Committee that was also required by the statute itself. This is a very, very interesting model. It's a private sector entity funded by a mix of public, that is to say, trust fund, Medicare trust fund dollars, and in a couple of years, what will be added to that is a tax or an investment, you can choose your word, paid by insurers and self-insured employers on a per capita basis. So ultimately, a total stream of funding somewhere between $500 and $600 million a year. What's very, very unique, though, and I think this is relevant to all of our work here, is the board governing this is not only scientists. There are some fantastic researchers on that board, but by law there are 3 representatives from industry who happen to be superb scientists themselves. There are 3 patients. There are people representing insurers, employers, healthcare delivery, and so forth, as well as the directors of AHRQ and NIH. A very, very different kind of conversation. Now, to say that this board is completely enthusiastic about patient-centered care would be a profound understatement. 2 weeks ago, the board met for the 3rd time, because they were just appointed in late September, and they actually we had a listening session out in St. Louis. Anyone here from St. Louis? Great. I don't know if you were able to join it. Oh, great. Thank you. I was quite struck, as I'm sure you were, by the fact that we split into little tables. Now, understand, there's a whole variety of folks there. So on one side of me is a guy who does health benefits for employees who work for a chain of regional grocery stores. On the other side of me is a guy who's funded by SAMHSA and works with some of the most vulnerably, seriously mentally ill patients. And so very, very broad range of input. Almost every single table at the top of their list for priorities for this institute was implementing what we know. Slightly different language from the different groups, but way, way at the top of the list. There's already so much focus out there. So this institute has not started its funding yet. The URL is pcori.org. Watch that space. I would expect that there will be some announcements in the relatively near future. I don't mean tomorrow, okay? So we don't need to distract yourself from the conference. I mentioned the Center for Medicare and Medicaid Innovation. $1 billion a year here to test different models of care, and yet ultimately they're going to be accountable for asking exactly the same kinds of questions. Can it work? Can it work here? Do we know how and why it worked? And if anything, the stakes are going to be higher for that center because for the first time, you know, Medicare and Medicaid have funded demonstrations forever. Some of them are extremely well done with evaluations, but when it's over, that's it. You know, we have a report, that's nice, and we keep on going. Now there's going to be a direct link with subsequent iterations of policy. This is a brand new path and brand new opportunity. But again, implementation science is what it's all about. A couple of other comments. We make available an opportunity for people who are innovators in healthcare but have no interest whatsoever in publishing, that they want to solve problems, and that's what they're passionate about, to share their lessons learned so we can learn from them on our Healthcare Innovations Exchange. For some of you looking for ideas or looking for what people are doing out there, it's a great place to visit, innovations.arc.gov. The Affordable Care Act has a number of provisions around quality. Now, I'm highlighting here some here where ARC is specifically mentioned. All of these, by the way, are authorized but not funded. But the larger point is, if you were to read the Affordable Care Act, I wouldn't recommend this for everyone, but I would guess at least 20% of the number of pages is focused on improving care delivery. That's a lot of pages. I've read a whole lot of them several different times. You could not write a movie script out of these pages, okay? Well, but because they don't actually all connect in a logical sequence. So the front end of the bill, there's a lot of directives to CMS to keep doing what they're doing now, but do more of it faster. And then, of course, there's the Innovation Center and PCORI. Later today, the Secretary will announce a national strategy for quality, which is a brand new idea, so that should be out later this morning. But they don't add up to a coherent script. But what I think it says is that policymakers get it in a really, really big way. They can come up with all kinds of schemes for financing and subsidies and all of that. But if we don't fix the core business of healthcare delivery, if we don't use all of our scientific tools to make sure that people get the best possible care wherever they are, this entire opportunity will have been wasted. So I wanted to leave you with some important questions, and I'm coming at this more from a policy perspective, but also from someone who funds research. So first, when does dissemination and implementation start? Historically, we've thought of that as a post-publication opportunity, right? Wait until it's out, and I've been on NPR, and then we'll talk about developing initiatives. I think there's at least one other major competing hypothesis, which is about priming the pump. And priming the pump, in other words, where you've got a lot of stakeholders along with you, is really important. First, when the actual big study in the home run is published, this isn't news to them. They've already been thinking about how they would do it. Secondly, in terms of really improving care, oftentimes the information that researchers have is astonishingly important to people running programs. So just to give you an example, when the Children's Health Insurance Program was first funded, we co-funded with a foundation a project to evaluate various aspects of its implementation in 9 states. So the interesting thing here was this bill gave states an enormous amount of flexibility. Does that sound familiar? And states could learn from each other, but along the way and very, very early on, there was a stakeholder panel guiding this, and the researchers were able to give to these folks very important, what I would call non-publishable but utterly vital information, like what other programs are children we're trying to reach enrolled in, right? If most of them are in WIC or in the school lunch program, well, bingo, I know where to deploy my people. You're not going to publish that. This isn't stuff we should be embargoing. A second big question that we struggle with a lot is, can we assess efficacy and effectiveness in improvement interventions concurrently? In other words, can we celebrate a worthy approach of rapid cycle research and learning, where we learn as we go? What does that look like? What are the problems with it, and so forth? How do we assess what's scalable? How are the people at the Innovation Center who are not researchers going to know this one, it looks good, and we should fund it, and this one looks really cool and innovative, but I can't imagine how you'd scale it. This is N of 1, and I just don't see it. What are the explicit roles for partners and stakeholders? I'm sure many of my colleagues at ARC and NIH would agree that it is astonishingly easy for us to write into a funding announcement, you must show credible commitment, blah, blah, blah. This is an IQ test for researchers, right? They develop the boilerplate letters. Everybody signs on saying, you know, we're definitely on board. You're giving this institution more money. But there isn't really a partnership there. How would we know that such a credible partnership exists? Should we be training bilingual champions, whether those are health professionals, health coaches, or some other group of people who understand enough about research that they know what research can do or not, but also understand the needs of the people who are providing care and running systems in which care is provided? And my personal favorite is, can research infrastructure also serve clinical operations? You know, at 10,000 feet, it feels like a great idea, right? First of all, we're all on our way to perfect electronic health records, right? Pretty soon, researchers will be able to pull right up to the server with a vacuum and put there and get a database. Obviously, there's a lot of hard work over the next few years to get there. But why should research be so separate? And we are seeing that in healthcare now, right? A lot of hospitals and other organizations collecting data for quality, for the most part, that's separate from, say, professional organization registries. In some kind of efficiency way, that doesn't feel like it makes a lot of sense. Some of the investments we've been fortunate enough to make with the Recovery Act funds are actually pushing the envelope on, can we do both? In other words, can we support rigorous research, and that infrastructure also goes on to serve the needs of the clinical enterprise? So at the end of the day, we want more about bringing healthcare and information and science to people's lives rather than making them navigate the maze that we've made healthcare delivery. And just to leave you with a bumper sticker, because these days it's all about tweeting and so forth. Thank you very much for your attention, and I'm thrilled by the conference. Yes, sure. Yes. I have time for a few questions, and there are mics here in the aisle, all aisles, I guess. This is always the awkward moment when someone getting up to run to the facilities is mistaken for a questioner. Hi, Jack.
Good morning, Carolyn. In your slide on the 3 things we need to worry about, you talked about displacing, what gets displaced. In your conversation, you talked about weaving into practice. And I think weaving is a better metaphor for what we're trying to do. The question is, how do new things get integrated into what we're doing? We have a clear need to slough off a lot of things that aren't producing value in care. But that doesn't mean we'll get new things in. So where do you see the research enterprise going to deal with the very practical organizational issues of integration of new ideas into current practice?
So I see a couple of key points for the research enterprise. One is we need more studies like the one done by Beth McGlynn, who's here today, where she tested her quality measures in the VA healthcare system, and actually had the opportunity to examine how they did when using these metrics, as well as how they did using different measures that are sort of spiritually aligned but a little bit different. And she was actually able to show that, you know, there didn't appear to be, I'm grossly oversimplifying, so find her at the break, there didn't appear to be a whole lot of this teaching to the test going on. In other words, we did well here because that's what we're being tested on. I think the challenge actually in question needs to be framed to this field, right? How is it that we prepare people and provide sufficient resources and encouragement for multidisciplinary teams. We all know this is a team sport that aren't about multiple disciplines of scientists only, but also have organizational leaders there. Because right now, we've got a lot of healthcare systems where, truth be told, the people actually at the very top level don't understand data at all. This is not how they were brought up or raised and have made their careers. And suddenly they've got to demonstrate that they thrive and do well in a world where we're asking for it. I mean, we, the policy enterprise, asking for it all the time. So to the extent that this is where I was trying to get to with bilingual champions, how do you bring people on board who can help carry the water and understand that it's actually important to test what we're doing rather than just saying, I've got a great idea, go do it.
Okay, one more.
Oh, great.
Hi. Is this mic on?
Yeah. Yes.
Okay. Hi. Lawton Cooper, NHLBI. That was very encouraging. Thank you very much for encouraging those of us at NIH, including NHLBI, who are trying to, despite the tough budgetary times, to move more, to encourage more researchers out there to submit grants in implementation science to NIH. But I think what we need help with, perhaps from ARC, is defining, so that we're not accused, as I was recently, of, well, I don't know, accused is the wrong word, but warned about mission creep, how to define what is uniquely NIH about what kind of research would be specifically NIH type research in this area.
Well, I would expect off the top of my head, because I think that this would be the basis for some very fruitful ongoing discussions and collaborations. And frankly, I would love to hear from people at this conference about that as well, because if there's one thing the current environment makes us very attentive to, is that we want to be investing resources as wisely as possible, because there's likely to be fewer of them. In general, I would think it very important that NHLBI, for example, is focusing on disseminating their work. I would probably expect that there'd be, and making sure that it's used in practice and so forth, I would expect that there'd probably be less attentive to, say, problems in diabetes care unless there was a very clear line between, diabetes is a risk factor for heart disease and so forth. The opportunity, I think, that we have not fully taken advantage of, which is why we're so pleased to be here, is before you launch a new initiative, shouldn't we be thinking together, and the same goes for ARC, about how our efforts, how there can be synergy between standing investments and so forth. So I'll just leave it at that. Because I think what's almost sinking this healthcare system is, well-intentions, initiative overload. Like the announcements in the supermarket and so on and so forth. We've got a passion, bingo, it's out there. We want to prevent diabetes, that's out there. We want to do this. And after a while, it's sort of like, whoa, I'm totally, totally lost. What does this have to do with my day job? And I think that question is where we could really come together and collaborate very effectively. Thank you.
Okay, time for the first set of concurrent sessions. I think most of the rooms are downstairs, but if you need help finding, there's some people at the registration desk, and we'll meet back here after the break.